Hello everyone, welcome to today's lecture. Today I'm going to talk about drugs to treat diabetes mellitus. Here's your objectives. I want you to realize that we're going to talk about diabetes in terms of diabetes type 1 and diabetes type 2. Some of this will be review, and we've planned it that way. Here's some terms for you to review on your own time. In looking at diabetes, we have at least 26 million Americans that have it. A lot of Americans have prediabetes, and approximately 25% of diabetic patients are undiagnosed. The basic gist of this is that diabetes is on the rise. When we look at diabetes, we look at diabetes type 1. This is where you have pancreatic beta cell destruction, where they have severe absolute insulin deficiency. We talked about this in earlier semesters. It can be either immune mediated or idiopathic. Most patients are younger than 30 years old when they're diagnosed. They need insulin just to live. So these are patients that require insulin, and not having insulin can lead to death. Diabetes type 2 is characterized by tissue resistance and declining beta cell production. So you have two things happening here. You may have insulin that's circulating that the tissue's not using, and you might have a decreased pancreatic response to glucose as well. A lot of times these people are diagnosed as adults, but it can be also in children. A lot of patients don't require insulin replacement to survive, but you'll notice a lot of patients in the hospital will require insulin. Other patients might benefit by having some insulin. Not controlling diabetes can lead to coma and potentially death. Diabetes is associated with other conditions as well. Pancreatic disease, drug-induced diabetes like via corticosteroids, malnutrition. It's related to pregnancy, which you're going to find out in later semesters. So looking at the short-term and long-term complications of diabetes, short-term complications of diabetes, you can have, in the absence of insulin, you can have hyperglycemia. Long-term complications of not treating diabetes, you have macrovascular complications like stroke, atherosclerosis, altered lipid metabolism, microvascular issues or damage to the small vessels, retinopathies, neuropathies, nephropathies. So there are lots of complications related to diabetes itself. So what are the treatment goals for diabetes type 1 and diabetes type 2? Basic thing is we want to keep someone in a normoglycemic state. So their glucose should be in normal range. And we want to minimize any sort of complications for diabetes, short-term and long-term. So a lot of this is linked together with other things. We're going to monitor blood pressure, lipids management. Diet is a big component. Exercise is very important with diabetes because it increases cellular response to insulin, and it decreases insulin intolerance or insensitivity. So we know that the suggested exercise 150 minutes per week. You're going to monitor other things like blood pressure, LDL, HDL. Look for any sort of complications. So we're also monitoring kidney function, nerve function, a yearly eye exam, things that we talked about in Common Health. So in addressing the insulin problem, there are a couple of basics here. For those patients with type 1 diabetes, we replace their insulin because they need insulin to survive. And now with patients with type 2 diabetes, we know that they secrete insulin. we may increase their insulin release by the pancreas. So there's different drugs that might do that. Sulfonylureas, meglinotides, incretin mimetics, DPP-4 inhibitors. Might decrease glucose absorption. So the alpha glycosidase inhibitors decrease the glucose uptake in the gut. Decrease liver glucose production, and might increase peripheral insulin sensitivity. So the biguanides and thiazolidinides do that. We might prolong activity of incretins, and these compounds stimulate insulin release and inhibit glucagon release. So the DPP-4 inhibitors. And then we have a new group of drugs, the SGLT2 inhibitors, where they promote glucose excretion by the kidneys. So we're excreting excess glucose in another format. So these are all different strategies to address diabetes. So in looking at drugs to treat diabetes, we kind of break them up into another way of categorizing them, and that's whether they're injectable or they're oral preparations. So injectable drugs are obviously going to be insulin, and then there's some other drugs like incretin inhibitors and amylin mimetics that are also injectable. The oral preparations are also listed for you. So if we look at insulin, its method of action, it promotes transport of glucose into the muscle, the liver, and fat tissue. It suppresses the release of fatty acids from fat tissue, preventing the formation of ketones. It accelerates potassium into the muscle cells, and it promotes amino acids into proteins. Notice the third function it has here, accelerating a potassium uptake. Sometimes you'll see patients will require to have their potassium dramatically decreased, and you'll see that clinicians in an ICU environment will give insulin IV as well as D50 to bring the potassium down. Okay, therapeutic uses for insulin. In type 1 diabetes, it's required. They need insulin to live. But with patients with type 2 diabetes, it's not quite as clear. So you can have someone who has symptoms not controlled by diet and exercise that might require some insulin. Maybe their oral preparations aren't working. They might require insulin. A lot of times you'll see them in the acute setting, where most of you are, where there's times of stress. So someone comes in, they're type 2 diabetic, and their glucose is high. Remember, this is a sympathetic response to stress, so it would make sense that their glucose might be high, and we need to help control it. Other places where we might see it, patients who are pregnant with suboptimal control of their glucose, and it hasn't been controlled with diet. Patients with parenteral nutrition. So you'll notice a lot of bags with TPN. If you read the ingredients and you look and it has all the components of what's in that TPN, you'll notice that a lot of times you'll also see insulin is also in TPN. You might have it in tube feeds. Someone who's in hyperglycemic crisis, they'll get IV insulin, and that's in an acute care environment. Someone who's hyperkalemic, so renal failure patients, they may require insulin, and that would be IV insulin. And then growth hormone deficiency. So this chart I want you to pay particular attention to. A lot of students will say, hey, in other lectures they told me this or they told me that, in terms of the onset and the peak about certain insulins. I double checked with what is expected for you to know by ATI in reference to NCLEX in terms of the onset and peak and duration of these drugs, and compared it to the book. And this is what is required for you to know for your boards. I will say that they do highlight certain drugs, and we're going to highlight them here as well. So that's really important for you to know, okay? That the numbers I'm giving you right now are exactly what you'll see on the boards. With that being said, ATI likes talking a lot about Lispro. Lispro is the first rapid-acting insulin that I have listed here. However, in our local environment, the short-acting insulin that's used that you will most likely see will be Aspart or Novolog. So the onset of Novolog and Lispro are significantly different. Aspart is faster. It has an onset of 10 to 20 minutes versus Lispro, which is 15 to 30. Peak for Lispro runs from 30 minutes to 2.5 hours versus Aspart, which is 1 to 3. And you notice the duration is essentially the same for both. The big thing for you you have to memorize is when does it start working and when's the peak. The peak is most crucial, I think, because that's when you'll most likely see your patient exhibit signs and symptoms of hypoglycemia. Another drug that you will most likely see, thanks to Susan Runda, who took a look at my slides and wanted me to add this for you, is another rapid-acting insulin, which is Aspart, and it's combined with another compound to make it even act faster. It's called Fiasp. The onset of this rapid-acting insulin is 2 minutes. So that's something for you to be well aware of. Another short-acting insulin, insulin glulicine, we don't really see that much, so I didn't put in the data for it. The last but not least, last short-acting insulin you may still see in many environments happens to be regular insulin. You might see as Novolin R or Humulin R. Its onset is slower than both Lispro and Aspart, and the peak is longer, so it's 1 to 5, and the duration is also longer. In looking at long-acting insulins, and so I'm lumping NPH and Glargine all together and as long-acting insulins. These are usually used as basal insulins because they simulate normal circulating amounts of insulin that go through your body. NPH, the onset's slow, it's 1 to 2 hours. Peak can be almost 6 to 14 hours with a duration almost all day. And then Glargine has an onset similar to NPH, but the duration is all day and it doesn't have a peak, so it stays steady throughout the day. You will most likely see Glargine out in the acute care environment. So this graph, I think I showed this to you in Common Health. It gives you a look at long-acting insulin like Glargine versus intermediate NPH, and then short-acting insulin. So it makes sense we give short-acting insulin to correct peaks in activity of the patient. So after a meal, obviously, versus basal insulin is a long duration. It hangs around all day and simulates what's normally hanging out in the body. There are different formulations for a lot of these things, and this is really important to pay attention to because it used to be we only had 100 units per ml, but that's not true anymore. So it's important to be able to read what the concentration is of your insulin. For instance, Lispro comes in either 100 units per ml or 200 units per ml. Regular insulin can come in 100 units per ml or 500 units per ml. And NPH only comes in 100 units per ml, but you'll notice that glargine can come in 300 units per ml. So the concentrations of these drugs are really important. This is a safety issue. It also can either come in a vial, which you have to draw up, or in a pen, which is considered safer. Continuous sub-Q insulin infusion. Here's a picture of someone with an insulin pump. Here, someone will be getting short-acting insulin. And the nice thing, you notice on the left, there's a picture of a glucose sensor as well, which is very nice. Insulin storage. So, it's important to refrigerate insulin, but not to freeze it. This will cause clumping, and you'll get an unstable mixture of the insulin. It is stable at room temperature for 30 days. You can mix in syringes and store them in refrigeration or room temperature. It depends on what it is. And always observe the expiration date on the vial. Adverse effects of insulin. Know the signs and symptoms of insulin. Know the reversal protocol. So if you have hypoglycemia, I know we talked about this. If your glucose is less than 70, you get 4 ounces of juice. You will be asked questions on how to treat hypoglycemia on the exam, based on whether they can eat or they won't eat, and that protocol is posted in your module. Other things. You can have lipohypertrophy. So if a patient keeps injecting themselves with insulin in the same place, it'll cause hardening of that area. That's an adverse effect. Drug-drug interactions should make sense. So if insulin causes hypoglycemia, if you give an oral hypoglycemic, you can further compound the issue. So you really want to watch someone closely when they're getting oral agents as well as additional or correctional insulin. Other drug-drug interactions to mention, beta blockers. So one thing with hypoglycemia a patient might experience would be tachycardia. If a patient's on a beta blocker, that's going to negate the tachycardia you might experience if a patient's hypoglycemic. So a patient needs to know how to recognize hypoglycemia without considering tachycardia. So symptoms they would recognize in themselves would be feeling sweaty or shaky or nervous or hungry would be the signs of hypoglycemia they would notice, because they won't experience tachycardia. And the dosage. So especially those that it's really important to match the dose with what the patient needs. And we're going to go over some orders, for instance. This is very important, especially with basal insulin. If a patient's NPO, now the standard protocol is to have the prescriber decrease the basal dose of insulin if they're NPO or they're going for a procedure. Here's a little graph. This is the basal bolus regimen. So you notice the little blue line across the bottom is the basal dose, usually a long-acting dose of something. So in this case it would be glargine, given once a day. And you'll notice that they're giving it the hour of sleep. A lot of times you'll see long-acting insulin given in the morning. And then we will also give short-acting insulin. You notice that they have the spikes in orange here, Lispro, Aspart, Glulicine, all to counteract increases that happen with breakfast, lunch, or supper. Now this is kind of an important concept. For those people that you may still see this happen out in the community, for those people that need pre-filled syringes, what they'll have is they'll get a pre-mixed insulin product, and you will see this on ATI as well. And usually it's NPH 70% with 30% regular. Remember, NPH can mix with regular insulin. So in this case, patients would get injected twice a day with this pre-mixed formulation. We don't see that much anymore, but this would happen in some instances. Nursing management of insulins. It's really very important to know how to treat insulin. In general, you need to refrigerate any unopened insulins. They need to be kept at room temperature for a month once they're opened. Pre-filled syringes can be kept in the refrigerator with the needle up. If you put the needle down, it will sort of find a clot there on the bottom. Another big thing is to rotate within a site. We know that different sites on the body absorb insulin differently. So if they're injecting on the right side of their abdomen, they should rotate within a circle on the right side of their abdomen, and then move to the left side of their abdomen, rotate within that site, and come back to the right side again, so that you sort of standardize the absorption rate. Look for adverse effects, and the main adverse effect we're looking for is hypoglycemia. Know the point of care blood sugar. It's important to get the blood sugar here in an acute care setting prior to the meal. An hour of sleep is generally what's expected for anyone who's on insulin. You cannot get a blood sugar from an IV line. You need to know the signs and symptoms of hypo versus hyperglycemia, and you need to memorize the immediate treatment of hypoglycemia. This is a slide to remind you that you need to rotate within a site. Timing. This is probably the most significant issue for a lot of nurses. It's really important primarily to know when insulin was given, when it's going to start to work, and when's the peak effect. So, for instance, if you're giving regular insulin at 7 a.m., when will you have the worst adverse effects? So what I'm asking for is, when's the peak effect of regular? So if I give it at 7, the peak effect's going to be 1 to 5 hours later, right? So that's going to be from 8 to 12. So if you give someone a SPART, when would you look for the worst adverse effects? Remember, the peak for a SPART is 1 to 3 hours. It's going to start to work, though, in 10 to 20 minutes. So if I give it at 7, the peak effect is going to be from 8 to 10. Feel free to review the nursing implications in your textbook. Other administration issues they're going to ask you about is NPH is cloudy. It's cloudy because there's particulate matter in there, so you need to roll that insulin, the vial, before you draw it up. You want to get a nice mixed solution. Other things you want to do, rotate within sites. Be sure to review your diabetes information from your previous course. Storage requirements are very important. Patient and family education. They need to know the signs and symptoms of hypoglycemia and how to treat it. How to minimize adverse effects, especially hypoglycemia. Other safety concerns. Know that insulin is a high alert drug. I think it's one of the top 5 drugs that we worry about here in the United States. And it's because if you give too much insulin, you can potentially kill someone. So there are certain things you have to watch for besides hypoglycemia. Knowing concentration, so be able to read the vial. There's a very big difference between 500 units per ml versus 100 units per ml. And there's an infection risk. Patients cannot share insulin pens. What we found is that even though if you change the needle, there's a flashback. So if that pen is used by one patient, it may not be shared.